Hello, my name is Komal Jhaveri, and I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York. And very, very delighted to be joined by my dear friend and colleague here, Dr. Iyengar.
Yes, hello. I'm Neil Iyengar. I'm a breast medical oncologist at the Winship Cancer Institute of Emory University in Atlanta, Georgia. And it's a real pleasure to join you, Komal, for this Cancer Unfiltered podcast. I think this will be fun as we oftentimes, the two of us try to digest new data drops together, and now we get to record our conversations and put that out there for everybody to consider. Also, it gives us an outlet not to bore our families at the dining table when we start talking shop. So,
Absolutely.
Always a pleasure to join you, my dear friend, and we're going to get into some data and some controversies.
Absolutely. So we were hoping to talk to you in this podcast about very many exciting data from breast cancer. And this being our first podcast together, we were hoping to start off this podcast with 5 different segments for you. The first one being data drop. We were going to talk about the newest, hottest data releases or publications that we need to know about as a community. The second, we were going to talk about hot takes, where we were going to share our opinions about some data sets and how do we think about just distilling that data down to what we would do for our patients in clinic. The third segment would then focus on some challenges. All these new data are great, but how do we break them down and how do we think about these data for patients in clinic? Are there controversies would be our fourth segment, and how do we deal with those controversies? What more do we need to do to address these controversies? And last but not the least, our real life scenario, a real life patient experience, a real life finding that I think we would love to share with all of you. And so with that, we're hoping to start our first podcast here today.
Yes. Well, thank you, Komal, for breaking it down for us. I'm excited. This is going to be a fun and hopefully educational conversation. So let's get right into it. Let's start with the first data drop. Let's drop that data on us.
Yeah, so thinking about data drop, I'm not sure I had a lot of new publications that I wanted to highlight, but I think the 2 important data drops that I thought we could talk about today were press releases. The first one being the Persevera press release. And so what is Persevera? Persevera is a first-line study in ER-positive breast cancer with an oral SERD giredestrant with palbociclib, as we know, compared to letrozole and palbociclib. Really trying to ask the question, should we be looking at oral SERDs in the first-line metastatic setting? Will that strategy delay ESR1 mutations, and will that lead to improvement in outcomes? And sadly, what we saw is that the press release said the study did not meet its statistical significance. There was a numerical gain. So I'm really looking forward to catching these data at the annual ASCO meeting. I think it's going to be the last day at the oral session. So stay tuned to hearing about the details from this study, because I think there's a lot more to learn about why there was a numerical gain, what happened with the lack of statistical significance.
Yes.
Now, in contrast,
I was going to...
Sorry, you could add
let me
something.
just interject real quick.
Yes, do it.
Yes, more to come, especially in the context of the lidERA data. So I think we're all really interested in how we put all of these data sets together. All right, you have more data for us.
We do have more data. And in contrast to Persevera, which was a negative press release, we did have a positive press release as well. And I thought that would be nice to mention, which is the 4Light-1 study. And what is the 4Light-1 study? That is looking at a selective CDK4 inhibitor, atirmociclib. And this data was in the second-line metastatic setting. So this is patients who've already had CDK4/6 inhibitors, and then there has been progression that has been documented for their tumors, who were then treated with fulvestrant with atirmociclib, the CDK4 inhibitor, compared to either fulvestrant alone or exemestane with everolimus. And based on the press release, there was statistically significant improvement for the combination of atirmociclib and fulvestrant. And so I think this is really nice. It's a phase 2 study. It's very exciting. It's an exciting new class where we're trying to see, can we get better selective CDK inhibitors, which can not only help us improve the toxicity profile, so less neutropenia because it's CDK4 only, but dare I say might be even better in terms of efficacy. And with that in mind, I think I'm excited about the ongoing phase 3 4Light-3 trial looking at first-line atirmociclib with letrozole compared to CDK4/6 inhibitor with letrozole. So important to keep these in mind.
Absolutely. As we see more and more endocrine therapy agents, it's also nice to have more molecular agents coming through the pipeline as well.
Absolutely. That was data drop. What about hot takes? So maybe, Neil, I can start with you there. and think about HER2-positive breast cancers. Let's think about the metastatic setting. And we have a lot of new data that has come out there in the first-line metastatic maintenance setting.
Yes.
So now I have a triple-positive breast cancer patient in clinic, ER-positive, HER2-positive, first-line, who's had induction therapy. We have the HER2CLIMB-05 study. We have the PATINA trial. What's your hot take? What would you do?
Well, we have options now, right? This is great. So, and especially with all of the different options that we have available to us now with the new data sets, I feel like I'm in the hot seat for this hot take. So I will try to give you, what I think my opinion would be in terms of putting all of this data together. So firstly, you mentioned that in this hypothetical case that the patient had induction chemotherapy. So assuming the patient pursued the traditional Cleopatra approach, we know that for both PATINA and HER2CLIMB-05, these were trials testing various maintenance strategies for patients who had some kind of response, either stable, partial, or complete, to induction taxane-based chemotherapy with HP. And in the HER2CLIMB-05 trial, this included patients with hormone receptor positive and negative tumors and added tucatinib to the investigational arm versus placebo and HER2-directed therapy with or without endocrine therapy. And in the HER2CLIMB-05 trial, there was a benefit for adding tucatinib to maintenance therapy. The benefit was accentuated or largely driven by patients who had hormone receptor negative tumors, although there was still a consistent benefit, albeit somewhat smaller, in the hormone receptor positive tumors. So I would say on the basis of the HER2CLIMB-05 trial, adding tucatinib to maintenance therapy improves progression-free survival. Now, there are, of course, downsides. So you do increase toxicity somewhat with the profile that you would expect for tucatinib, primarily diarrhea, and have to watch those LFTs as well. The alternative, of course, is the PATINA trial, as you highlighted. So in PATINA, this was also a study that was investigating maintenance approaches, but specifically for hormone receptor positive tumors. So this is that triple positive tumor that you highlighted. And the question was, does adding palbociclib to maintenance therapy improve outcomes? And indeed, in the arm that got palbociclib in addition to maintenance HER2-directed therapy with endocrine therapy, most of the patients received aromatase inhibition. There was a median progression-free survival of 44 months, so really quite an impressive extension of progression-free survival compared to those who had traditional or current standard of care maintenance therapy. So I would say when we put these two trials side by side, for those patients that have triple positive tumors, as you outlined, I would favor adding palbociclib to maintenance therapy. For those who have hormone receptor negative tumors, I would favor adding tucatinib. We can have a debate about if there's a history of CNS disease. You might reach for tucatinib instead because of its CNS activity.
So that was HER2-positive metastatic breast cancer. What about ER-positive when we think about hot takes? I think the one new thing that we have learned is we saw the newest NCCN guideline updates, and those are so helpful when we think about reaching out to newer drugs for patients even before approval. We saw EMBER-3 regimen with imlunestrant and abemaciclib has now been NCCN endorsed. And we know that the paperwork for filing with the FDA is in for ESR1 mutant tumors. We also have heard giredestrant, another oral SERD with everolimus. The PDUFA date for that is now December of 2026 as well for ESR1 mutant tumors. So let's say tomorrow, we fast forward to January 27, we have both of these drugs available for patients, and that January 2027 is tomorrow. And you have an ESR1 mutant tumor where you're reaching out for a combination regimen. Which one would you choose, and how would you think about it?
It's a great question. So my hot take on that is that, let me back up for just a second and say that, I think your point about if we're thinking about a combination is an important point because many of us do favor a combination in the setting of an ESR1 mutated tumor. But I think we can also make the argument based on the EMERALD data, going all the way back to EMERALD now, it feels like the data is evolving so quickly, that we could consider elacestrant monotherapy, our original oral SERD approved in this setting, And I think now we have more options, which I'm happy to see based on the trials that you just outlined. So in EMBER-3, of course, this led to the approval of imlunestrant as monotherapy, and now we're awaiting imlunestrant abemaciclib, as you highlighted as well, because there was superior performance in terms of PFS compared to imlunestrant monotherapy. I think on the basis of the EMBER-3 data, when I look at imlunestrant versus imlunestrant plus abemaciclib, which was clearly superior, that would compel me to reach for the combination of abemaciclib with imlunestrant. And so in a case that you were highlighting, a patient with an ESR1 mutated tumor, imlunestrant plus abemaciclib, I think, would be something I would reach for. However, we're in this in-between period, right, waiting for approval. So I might start with imlunestrant and hoping that I can add abemaciclib soon. You also mentioned giredestrant and everolimus. This is where I think shared decision-making with our patients is really important because the toxicity profiles amongst these different options are really distinct. And so while we know how to manage these toxicities pretty well, there is burden to the patient. So I would start off by thinking about whether or not I want to use monotherapy or combination therapy. Based on EMBER-3, I would favor combination therapy and maybe start imlunestrant while waiting for the approval status for the addition of abemaciclib. And then finally, considering other potential agents or therapies coming through the pipeline, I really think we have to have a conversation with our patients about the various toxicity profiles and make the right choice for that particular patient.
Completely agree with you. I think the only one point I would add to that, and I would do exactly the same that you did, it's a shared decision-making process with toxicity profiles. It's good to have choices. We're excited about that. One thing that we have learned or uncovered is the RB1 mutations. That is a potential mechanism of resistance to CDK4/6 inhibitors. And while we think that that's not that common, it's not that rare either. The acquired rate for RB1 alterations is about 10%. And we would think that in that particular scenario, that a CDK4/6 approach beyond CDK4/6 inhibitor would not necessarily be that effective. And so maybe we would want to reach out for everolimus-based approaches there more, which also highlights the fact that we need to be paying close attention to these NGS reports in our busy practices beyond ESR1 and beyond PI3K to be able to make those decisions with our patients in clinic as well. But thank you for sharing that.
I think you raise a really important point because I actually am very passionate about this point, and that is that the NGS data, I think, is very important because while it identifies targetable and actionable lesions, it also gives us a sense of the natural history of the disease. And I think ultimately this is what you're alluding to, and that is that it helps us understand resistance, but it also helps us to understand preemptive resistance, if you will. So if you identify an RB1 mutation, there are others that I think that are also important both for acquired and pre-existing resistance. This really helps you sequence your therapies. Now we're practicing in an era where we don't yet have the data sets to match the predictive capabilities of the NGS profiling. However, I think that if you're sitting with the patient and you have an idea of what they may or may not be resistant to, we can't ignore that data.
Yeah, no, absolutely. And I'm glad you mentioned elacestrant as well. We don't have prospective phase 3 trials for combinations with elacestrant, but we do have trial data from Elevate looking at these same combinations. We have data for elacestrant and everolimus. We have data for elacestrant with abemaciclib. And so I think it's nice to see all these combination data with these various agents because that's what we're going to do for these tumors and further improve the durability of the benefit we can derive.
Absolutely. So let's talk about challenges with all of this emerging data. Can you highlight for us one of the key challenges that we're all faced with some exciting emerging data? And let's focus specifically on hormone receptor positive metastatic breast cancer. And I'll tell you what, I'm going to throw you the challenge, and that is SERENA-6. I think that this is something that, we're excited from a scientific perspective about looking for molecular progression, using cutting-edge technology to detect progression before we classically see progression. But then, of course, there are downsides. How many patients do we have to screen? Is it truly improving long-term outcomes? What's your take on this challenge?
Yeah, no, I think it is a good challenge, but it's also a challenge. And I think, the one thing that I want to probably start off by saying is that it's exciting to see what is really going to happen because we have the ODAC committee for SERENA-6, April 30th. So that's
up.
coming up very, very soon. And very soon we'll know whether this challenge is really going to be a challenge in clinic that we will have to sort out. So let's talk about this a little bit, right? So SERENA-6, just to back up and say, is certainly a very important study, a very large study, trying to ask the question, can we use ctDNA guidance for molecular emergence of ESR1 mutations without showing progression on a radiological scan, which is how we usually switch therapies? And can we make a switch based on molecular progression without radiological progression? And certainly the trial randomized patients who were on first-line therapy by looking at serially collected ctDNA samples to see if there was an ESR1 emergence. And if there was, without radiological progression, they got randomized to continuing the same CDK, but the ET backbone was switched to camizestrant and oral SERD versus continuing the same first-line therapy. And by doing that switch in that patient population, there was an improvement. What was also compelling was looking at PFS2, which was also better in the switch arm compared to continuing the first-line therapy arm, and certainly very impressive curves for quality of life as well. But then what is the challenge if everything is so good? There are a few challenges, I think. While we're trying to be so novel and current with how we want to utilize ctDNA to actually track tumor biology in real time for a patient, which I'm sure from a patient perspective is super appealing, right? For a patient to know, this is what's happening in my tumor, this is the mechanism of resistance, this is what I can do to address it. I think that sounds very cool.
Yeah, patients are asking for this.
Exactly, and we want that for our patients. But the challenge also is that the control arm certainly did not make any switches. We knew something was happening there. We continued that same therapy. And then what did they get at the back end? And now we have data such as the giredestrant Evro and the EMBER-3. And could we, at radiological progression, offer them those therapies that were not reflected in the SERENA-6 patient population, right? And could they still derive that benefit at the back end? Or should we be doing this? And why is that challenging? Because we have to screen a lot of patients. We have to do the serial monitoring. And so we have to figure out how many people should we screen, how many tests will it take, and then exactly how many patients are asymptomatic with this emergence without radiological progression. So it does have some logistical challenges that we have to really sort before we can think about utilizing this for all. So I think, again, it's going to be an art of medicine. I think it's going to be something we are going to be discussing with our patients in clinic and reviewing what we understand about the data, and then let them decide how they want to understand this without having the pure OS survival benefit, having other options, understanding that this is what we would need to do and whether they would want to do that. And I'm sure there are patients who would want to, and there are going to be patients who might not want to. And I think the good news is we have something for both scenarios.
Totally agree. I think that's well said. You know, one thing that I think about a lot is that in SERENA-6, about half of patients who had an ESR1 mutation were detected on that first test, right? And so I wonder if we focus specifically on those patients who had an emerging ESR1 mutation. In other words, we isolate it was negative and now it's positive. I wonder if the magnitude of effect, the benefit, would actually have been even larger in SERENA-6 if patients who we knew converted from negative to positive made up the majority of that trial population. So, you know, there are unanswered questions here. It's a challenge, but I think you outlined it very nicely in terms of how we might be able to grapple with that in clinic.
Yeah, no, I completely agree. I think, you know, patients were enrolled on SERENA-6 if they had first-line therapy for at least 6 months.
Right.
And the median time to ESR1 mutation emergence was 22 months, with 50% having the first test positive. So the question is, if the median time is 22 months, do we want to start at 6 months? Could we start at 12 months? What about 18 months?
Right.
Do we have to do it for all? There were 3,000 patients who were screened, 300 who were randomized in the end. So how do we address this? And what kind of assay should we use? Is there a potentially easier accessible, maybe even a potentially cheaper assay just focusing on ESR1 mutation, or do we want to rely on just assays like Guardant and others, which gives you the entire NGS profile and use that serially? So those are the few things that we still need to iron out.
Yeah, I'll throw you another one in that, right? Adjuvant use of an AI, right? They may have had a nice disease-free interval, but do you add up their exposure to an AI? Does that compound their risk of ESR1 mutation, or does it alter the timeline? So I think if we add this list, we could probably, between the two of us, we could keep adding to it. But I think it is exciting that we have this potential approach.
I think it's very exciting. We like these challenges. We want to address them. We want to have these options for our patients and figure out that challenge with them in clinic.
Absolutely.
All right. So now that we have challenged ourselves with all the challenges we're going to face, why don't we move on to controversies? Because yes, we're very excited about so much data coming out. And yes, we're very excited about all these various options for our patients. But those options also bring in some controversies about how do we want to think about one strategy over the other? How do we use one strategy before the other? Should we save one strategy for later? So why don't we try and address that as our next topic? And maybe you can kick us off with, in HER2-positive metastatic breast cancer, in the first-line setting, we have 3 data sets. We talked about PATINA and HER2CLIMB as maintenance regimens. And then we have DB09, because how could we not talk about DB09 with trastuzumab deruxtecan and pertuzumab in the first-line metastatic setting, where there is no induction, and then there is no real maintenance, if you will. We were treating for progression or toxicity, and then we were allowed to do maintenance of or continuation of therapy for those reasons, but not the true induction maintenance like the other trials. So how do we think about these 3 data sets? How is it controversial, if it is? Because how do we think about which patient is appropriate for what strategy, and how would you deal with it?
Yeah, great question. So I will say something controversial, and that is that, I think that this discussion has largely been framed in the context of an induction maintenance approach versus a treat to progression approach. And I don't quite see it that way, and you sort of alluded to this, actually. I don't fully see it that way because it's really, in my mind, start with your most effective therapy, and then we'll see what happens, essentially. And the reason why I say that is because, for example, if I'm starting off with a DESTINY-Breast09 approach, where I'm starting with trastuzumab deruxtecan and pertuzumab in combination in the first-line setting, it's not necessarily that I have chosen a treat-to-progression approach over an induction maintenance approach. What I do set the expectation with my patient, if I'm choosing that route, is that, yes, we will aim to treat to progression. However, if we find ourselves in a situation where we need to dose reduce or where we even need to stop therapy because of tolerability issues, I don't think it's unreasonable to then pivot into a maintenance type of approach. So if for whatever reason I have to drop the trastuzumab deruxtecan and the disease is stable or the disease has responded well, I don't think it's a situation where I would say, all right, I've finished first-line therapy, I'm moving on to second-line therapy. This is an area where I would continue the HER2-directed therapy, add Herceptin into that pertuzumab, and then add in endocrine therapy if they're ER positive. Now, we could take that a step further and say, would we then integrate PATINA, or would we then integrate tucatinib from HER2CLIMB-05? And I actually think I would, because we saw those results and they were very convincing, and I do think that that's independent of the induction regimen. So ultimately, my approach in this controversial setting, as you nicely put it, is that I would start off with what I see as our most effective therapy in the frontline setting, and DB09 demonstrated that. Putting my scientist hat on, we hit the primary endpoint, and this is more effective therapy demonstrated by DB09 than the Cleopatra approach. Now, I do not think that's mutually exclusive of maintenance, and if we have to stop T-DXd because of tolerance issues, I would switch into a PATINA or HER2CLIMB-05 type approach.
I completely agree with you. I think, DB09 tells you to treat until progression or toxicity. So if there was toxicity, you could certainly stop early. I also want to highlight a big controversy that we keep discussing with DB09, right? I think we keep saying we want to do what we do with Cleopatra. We want to do the induction approach because the quality of life is so much important. But I think the controversy here is, apart from first-line HER2-positive metastatic breast cancer, is there any other subtype or any line where we don't treat until progression or toxicity and go with the induction approach? We don't.
We don't. I mean, that's a perfect point, right?
We just don't.
We don't, yeah.
Right. And I think what we have forgotten because of the quality of life is that the reason we stop after 6 months of induction with THP, with Cleopatra, is not because we were brilliant scientists who knew that 6 cycles was optimal and that's what the tumor needs. We are good, but not that good. But I think it is more because neuropathy is a big challenge.
Right.
So we did actually treat until progression or toxicity, even in that setting. It just so happens that we have appreciated, and our patients have appreciated the quality of life on just being on HP or endocrine therapy with HP. And we want such an option for our patients. But DB03, median progression-free survival is 28 months. 29 months, right? We don't stop there and say, I'm going to give 6 months and I want quality of life.
Right.
And patients are not going to, necessarily have to continue. So I do think, we are sometimes, trying to do good for our patients, but we're forgetting some things that we were actually intending to do for them just to improve their outcomes. I think from a research effort, I want to say not only do we have Demeter, which is trying to address this T-DXd induction 6 cycles followed by endocrine therapy, doesn't address the DB09 really. We need your next generation, as you said,
right.
HER2 climb PATINA post T-DXd P as an option, and hopefully we can treat for response so that our ultimate goal is cure, dare I say, or improving outcomes even more. And there are many efforts, such as the SAPHO study within the Translational Breast Cancer Research Consortium, where we have a kitchen sink approach.
Yeah.
We're trying to give them T-DXd, we're trying to give them tucatinib, all with a few cycles, not because we want to just use it all. I think we're trying to cure HER2-positive metastatic breast cancer. And I think that's why, to me, having T-DXd plus P until maximal response, and then a maintenance regimen at the back end to see if we can actually get there, or ctDNA-based monitoring and trying to have studies. And we actually have that at our institution called the Horizon study, where we're trying to use ctDNA as a way to identify when we could actually stop and not even have any maintenance and follow them through after. So I think more controversies to solve in this topic, but I think for now, we have a lot more work to do.
We do, and it's interesting to your point about maintenance. I think we're also seeing clinical trials where I would raise the question, and this will again be controversial, is it really, are we still in the maintenance setting? Certainly, you could ask that question of HER2CLIMB-05, adding tucatinib, for example, increases the GI toxicity and diarrhea. So is it truly that quality of life that people were getting with the antibodies alone? We've got other trials going on, for example, inavolisib being tested for patients with HER2-amplified PI3 kinase mutated tumors. And I would truly ask the question there, is adding inavolisib to the maintenance setting, is that truly a quality of life situation when we know that inavolisib is associated with several toxicities as well? And so I go back to the original point that I think both of us were making, and that is that efficacy is really critical. And I would say in the first line setting, this is where we might be able to move that needle, as you were pointing out, and maybe get to cure. And so this is a setting where I would really use our effective agents like T-DXd and pertuzumab up front. And then I think as we see these trials come out and the maintenance setting evolves, we may no longer be in a situation where we're just talking about HER2-directed therapies as our maintenance approach. And now it becomes probably less of a quality of life issue and more of an efficacy issue.
Yeah, no, absolutely. I think our ultimate goal is always going to remain, can we cure now HER2-positive metastatic disease, and how can we continue to further improve outcomes? We've come a very long way with the subtype, but can we continue to do that? And until we resolve these controversies, I think that ultimate goal, that ultimate, dedication of what we want to achieve for this patient population is always going to stay.
For sure. All right, so we've talked a lot about controversies and our hot takes and all of the data. Let's make it real. Let's talk about a case. Why don't you tell us about a patient that you've seen in clinic that highlights some of the controversies and data that we've been discussing?
Yeah, no, I think that is what exactly we want to talk about, right? Because ultimately what matters is what do we do with patients in clinic and what do we learn from our patient experience that we can then again bring back to our patients, right? And so I think a very interesting case that made me really think about or reminded me how complex ER-positive disease truly is and how heterogeneous ER-positive metastatic disease truly is. So I have a young woman in her early 50s, actually an ophthalmologist by profession. And she came to me with the BRCA mutation, had already had, CDK4/6 inhibitors. She'd had a PARP inhibitor. In fact, had a very short duration on the PARP inhibitor for some reason. Did land up getting trastuzumab deruxtecan for HER2 low breast cancer. Again, had a relatively short benefit with that. Long story short, 12 lines later, including 4 clinical trials. Wow. Very motivated patient, landed up doing well on multiple clinical trials for a long period of time, including was exposed to a radioligand therapy trial, has seen antibody drug conjugates, including sacituzumab and trastuzumab deruxtecan.
She's seen it all.
She's seen it all. And the disease now has really become very tricky, where she's had extensive liver burden and liver metastases, extensive peritoneal disease, really rapidly accumulating ascites with a Tenkov catheter in place, and deranged liver function tests with elevated bilirubin in the 3s. Oof. And so I'm having a very tough conversation after she's just discharged from the hospital about how do we approach this and what do we do? And I think we had a very tough conversation about how hospice conversation and supportive care and just maximizing supportive management could be a very valid and appropriate strategy given that she's had 12 lines of metastatic therapy.
Absolutely.
And we had done a Guardant recently, and that did show an ESR1 mutation, and we had not treated her with an oral SERD for her metastatic disease. And normally when I'm thinking about chemotherapy and endocrine refractory disease after 2 or 3 lines of endocrine-based regimens, I'm not necessarily thinking about endocrine therapies again. I'm sequencing chemos and antibody drug conjugates.
We usually don't go back.
Exactly. But in this case, we discussed hospice. And, of course, she's very young. Her mother is there. And is there anything else could we do? Was the conversation, like every time we would have. And we were like, okay, the only one thing maybe we could potentially try is an oral SERD because of this ESR1 mutation. I don't know how it will work. I don't know if it's going to be easy to do. And the LFTs being an issue might also be something we have to monitor closely. We decided to do half dose, so 200 milligrams of imlunestrant oral therapy for her because of the liver function derangement. Very quickly, I see her weekly for labs, every 2 weeks in clinic. And 2 months later, I'm seeing her with her bilirubin and AST, ALT kind of normalizing slowly. Her ascites, which she was draining 1.5 liters a day, became 900 cc's a day. Wow. And then I see her at the 4-month time point with a scan with really good response all over.
Fantastic.
Draining 50 cc's a day instead of 1,500 that she was draining before.
So she's feeling better too.
Completely normal liver function enzymes.
Amazing.
Being able to eat. And we then started talking about, could we improve the durability of this monotherapy? And could we get greedy, as we greedy oncologists always are?
What are you going to add?
What can we add? And so she had already seen abemaciclib in the past, and certainly that could be tried 4 years down the line again, because why not? But we had never treated her with everolimus for her disease, given her rapid progression in the early days. And so we tried to use the data from the giredestrant Evero study. We have phase 1 proven data for imlunestrant and Evero. And I started her on everolimus. And I'm yet to see what's going to happen next. I started her at a lower dose. But this just reminds me of, one, we don't know how heterogeneous this disease is, and should we not be thinking about endocrine therapy, even though the trials want us to think about, using endocrine therapies up front. But I think from a patient and case-to-case basis, an oral SERD should be offered in an ESR1 mutant tumor at some point at least. And there might be a patient where it might not work, and there might be a patient like this where it would work. And I think we might have to do this trial and error until we get really smart about understanding the heterogeneity and the biology of ER-positive cancer.
Yeah, I completely agree. I think that trial really highlights some important points. And I mean, even going back to Emerald, there were patients who received chemotherapy before coming on trial. And so
20%.
Right. And so we have evidence that an oral SERD can work after chemotherapy. But I think you're right to point out that we don't traditionally think about going back to endocrine-based therapy. But I think if you have a patient who has progressed rapidly through endocrine therapy and for whatever reason you hadn't checked for an ESR1 mutation and you switched to cytotoxic therapy, and then you discover an ESR1 mutation, I think it's very reasonable to then try an oral SERD. Now, I will say that your point about heterogeneity of disease is really important because I have certainly had patients in whom I've gone back to an oral SERD after chemotherapy and they've responded. But I have a very similar case who unfortunately had multiple lines of therapy and we later detected an ESR1 mutation. So we went back to, in that case, it was elacestrant, and unfortunately did not get a response. But I think it highlights, though, another point, and that is that these drugs are very well tolerated, the oral SERDs. And so when you are in that kind of situation, the risk-benefit discussion changes. It's not like we're throwing something at a patient that's going to completely compromise their quality of life and poses all kinds of risks, and therefore any tiny benefit you might eke out of it is really not worth the risk. That's not the case with oral SERDs, and I think that's really liberating almost to have a treatment option that offers us a different risk-to-benefit ratio than what we're potentially used to and really supports at least trying the oral SERD in the setting that you outlined.
Yeah, and I think, we as oncologists, this is not a new thing. I think we've done that with tamoxifen, in
Yes.
very, very pre-treated patients. We've done that with aromatase inhibitors. We recycle things
Yes.
sometimes in the end, depending on a patient and where they are and how they are mentally as well, in addition to how their cancer is behaving physically. And I think this is just a reminder that sometimes we just learn from this trial and error. And I think, as you said, the heterogeneity is why one SERD did not work and the other one. It's not a thing to say that, this SERD is better or this SERD is not.
Right.
I think SERDs work. It's the heterogeneity sometimes that determines why it worked in a certain scenario versus it didn't. But I think, again, the point is with an ESR1 mutation, we have an option, and I think we should try and at least attempt to see if there was going to be benefit in a patient's trajectory in their breast cancer journey.
Yes, great points. Well, I really enjoyed this conversation, and I look forward to getting even in greater depth in our future conversations for our next episodes.
Absolutely. So thank you so much for joining us today. Looking forward to seeing you guys and having further discussions with my partner in crime here for our next episode.